Well, it's, as you know, it's FDA approved for patients who failed VEGF therapy in the second line. You know, we've long advocated to try to move it up to the front line because it has a really preferable, in many ways, therapeutic index, has a pretty good toxicity profile for most patients. Less than 10% of patients have to come off because of toxicity, and there's a small group of patients who get a durable response with treatment, sometimes even after the treatment stops. Now that percent is low. It might only be 5 or 10%, but it would be exciting and important to move it up to the front line for those patients so they might be able to skip some of the more toxic treatments. But to do that, I think we need to do a much better job of identifying predictive biomarkers, and that's what I'm talking about today, looking at not just immune histochemistry, but RNA sequencing, whole exome sequencing, looking both RNA and DNA. And we're getting a glimpse that maybe those, when you combine several aspects of the tumor into a model, that you might be able to better predict who can receive single agent therapy, which is not just important to bring the treatment into the front line, but now we're going to the adjuvant setting, and there it's even more important to make sure the right patient's getting the right treatment, because most of those patients are already cured by surgery. So hopefully we can extend what we're learning in the metastatic setting into earlier disease, so we can really identify the patients who should get this treatment.